Hello, this is a supplementary recording for the Regional Disaster Health Response System. We are specifically presenting on pediatric respiratory distress using a case discussion. My name is Kelly Corbett. I'm one of the PICU attendings here at Dartmouth Health. And along with me are, would you guys like to introduce yourselves?
My name is Kate Miller. I am a PICU nurse here at Dartmouth Health Children's, as well as a second-year medical student at the Geisel School of Medicine.
I'm Randall Knapp. I'm a respiratory therapist here at Dartmouth Hitchcock. I've been doing this for almost 20 years. I'm the clinical coordinator of respiratory care and the ECMO coordinator as well.
And my name's Eric Comtois. I'm also a respiratory therapist here at Dartmouth. I am a transport respiratory therapist.
Just as a reminder for this webinar series that this content is not meant to be a substitute for medical advice, and that these are the opinions of those of us presenting and do not represent the official policy from the regional response team or U.S. government. None of us have any financial interest or relationships to disclose. The main learning objectives for this presentation are to review the prior concepts from the last 4-week seminars and to focus on tips and tricks that can help the smaller community hospitals that may not have all the bells and whistles of a larger academic or pediatric hospital. We will finish on some comments for transportation and transfer as well. The key theme for this talk is really to know your equipment beforehand. Before you're forced to jerry-rig any equipment in the face of a sick kid, look into your storage closets and know what equipment you have ahead of time. This will also help inform your sense of urgency when faced with a sick kid to know whether or not you can safely board them or if you need to triage them out sooner. And for those hospitals that don't see pediatric patients as frequently as the rest of us, be mindful of what kind of tools you might be able to rely upon for assessments. So simple things like Broslow tapes offer helpful visual tools for knowing sizes and weights. There are pediatric vital sign cards out there. I have included a picture of our CHAD card for those of us in the northern New England region. We distribute these CHAD cards to our community hospitals. Or there's various apps available for download that include pediatric vital signs.
One of the questions that came up with some of the prior talks in this series was what advice we would give to a nurse who had to act as a respiratory therapist in the face of a pediatric patient and no RT on call. So the biggest thing that we can stress is to know your resources. While there may not be an RT on call in your specific hospital, you can look to what centers are within your hospital system that might offer referral services or advice. You can always call other hospitals to ask to speak to the RT supervisor on call at the moment for advice for things like setup of suction and setup of respiratory equipment. At our institution, we do offer that service to other hospitals in our system. Another point is to think ahead, knowing that we're in a season of high respiratory illnesses. Maybe take a few minutes when you do have a respiratory therapist around and ask some questions that you might need to ask if they were not there on a given shift. Another thing to consider, as Kelly mentioned earlier, is knowing your equipment. From a nursing perspective, often in the ED you do not have a lot in your bedside cabinets that's there and ready for you. But when you have a sick kid and a full ED, there's limited resources for people to grab things for you, so it can be really tough to be running around. These are some things that you might want to think about if you do have a patient who you might look at boarding for a given period of time. One point to note is that some of these things can be borrowed from other units in the hospital if you don't happen to have them. So for example, you could reach out to the newborn nursery, or if there is a NICU in the hospital, for some of the IV pumps and things like that. So just think ahead and borrow things perhaps before you might need them.
So let's talk through a case. Let's say that you have a 1-month-old infant, full term, coming into your local ER with cough and now a couple days worth of increased work of breathing, but notably no apnea, no cyanosis, Perhaps this kid was seen by the pediatrician already this week, told they had a viral illness, advised for some supportive care at home. But as the pediatrician had warned, if they have any sort of increased work of breathing, they should go to their local ER, and that's what they have done. The kid comes in with a decreased interest in taking PO, but is otherwise making a good number of wet diapers. One point that I want to stress is about pediatric and weights. Just to offer a word of caution, be mindful that parents often will confuse pounds and kilos, and whenever possible, please try to get a weight for your patient before dosing any medications. As just a quick sniff test, this is what I teach my students, is kind of have a baseline sense of, is a weight kind of reasonable for the size child in front of you. An average newborn is about 3.5 kilos. 10 kilos is roughly 1 year of age kiddo. 20 kilos is roughly around kindergarten. 40 kilos is roughly around middle school 12-year-olds. And so if you're getting a number that's grossly off from this, it's a good point to double check and put the kid on a scale if possible. Smiling, a little guy, but belly breathing, somewhat tachypnic. Let's say that you listen and there's some coarse breath sounds, but the perfusion's great. Moist mucous membranes, the skin is warm. But let's say that you get a pulse ox and it's 87% on room air. So the initial approach, you already are suspecting that this is viral bronchiolitis, and the guidelines pretty much tell you don't do anything. Don't do chest x-ray, don't do labs, that includes your viral panel, don't do antibiotics, don't do steroids, don't do racemic epi, don't do albuterol, don't do chest PT. And that's fine for a kid that looks great from the door and your general gestalt is for viral bronchiolitis. So how do you then stratify? Various hospitals will use their own internal clinical pathways, or your referral center may have one. As this webinar has gone over in the last few weeks, there are many versions that all roughly say similar things. The first week of this webinar series had one from Mass General for Children. CHOP and Seattle Children's also have them available online for use. Whatever one is personally of your choosing, that's fine. They're for your benefit.
This is the scoring tool we use here at Dartmouth. You've probably seen some reiteration of this throughout these talks. We use the WARM score, stands for wheeze, airway exchange, respiratory rate, muscle use. We find it important to use a scoring system, just keeps everyone speaking the same language. It's a good trending tool to see how the kid's responding to therapy, if he's getting worse, if he's getting better. If you're going to adopt one of these tools, it's probably best to score with a partner, just till you get used to the frequency, and because some of these are subjective. So
I think one thing to be mindful of is that various centers will use different scores. So when you're calling to transfer a kid, not all centers will refer to the same numbered score. So these are great for objective trends over time, but not for a universal language between hospitals.
And suctioning is going to be very important with this population. Their nares get clammed up pretty quickly. How you suction isn't necessarily as important as that you're suctioning. There's multiple different methods. There's the bulb syringe down below. There's nasal aspirators there. You might want to limit your pressure with the pediatric population, maybe no less than -100. It's kind of a good guideline. You can flush one nare with saline as you apply suction to the other side to really clean them out. Deep suctioning isn't necessary most of the time. You can cause trauma and really work the child up, get them really excessively annoyed is a good way to put it. And you don't want to cause any damage or edema to the back of the nasopharynx.
So some initial steps that you want to think about, as we mentioned before, always thinking about suctioning first, especially ahead of feedings. Hydration is tenuous in these kids. You'll always be trying to think about their fever control, You can use acetaminophen, 15 milligrams per kilo is a standard dose. Thinking about hydration status, PO is definitely allowable if it is within the realm of possibility with their work of breathing. To optimize their PO status, you want to make sure that you do really clear the airways well before trying PO hydration. And then if you are in a situation where mom's asking if they can feed, make sure that you have someone, typically the nursing staff, at the bedside to observe them to make sure that they're not desatting, becoming bradycardic, or having really significant work with that. And then you're going to start out by seeing how they do on some low flow oxygen. You want to try to keep their oxygen saturations above 90%, and that can usually be achieved with 2 to 3 liters per minute.
So low flow is perfectly accessible. Low flow dry gas versus bubbler. Bubbler can be used. It's a little water bubbler. The taxonasal cannula has a high pressure pop-off valve built into it. Yeah, but more importantly, humidity versus aerosol. Humidity is king in this situation. You can use aerosol because you're not completely bypassing the kid's upper airway in natural humidification system. But aerosol does produce a lot of droplets, which can make a lot of condensate and get tied up in the tubing and the nasal prongs and flush into the child and really get them worked up. But proper humidity is important because without it, you can disrupt your mucociliary transport system. It'll thicken secretions, the airway become irritable, and prolonged deficit can yield structural damage. So a humidifier, they come in many different shapes, forms, sizes. You probably have one somewhere in your institution for some reason, and you can harvest that. More importantly, get that gas up to 37 degrees. The more gas, especially if you're bypassing the upper area in any way or very high flows, you should want that gas humidified. In the air oxygen blender for precise FiO2 delivery, if you work in a major medical center, you probably have plenty of these, but a lot of centers don't have that because they don't need to mix gas frequently, or they have ventilators that can mix the gas via internal turbine. So it's a very precise specialty piece of equipment. It's expensive and it's supply chain limited right now. They're hard to come by. But if you have access to compressed air and compressed oxygen, you can mix those flows without a blender and still give precise FiO2s. And these are just 3 adapters I found in the back room of our equipment supply area just to figure out a way to mix these 2 gas sources. And to the right there, we have a high pressure pop-off valve. Those are easy to come by. It's a manifold, so the pressure can't inadvertently build up. I mean, granted, we practiced high flow therapy for a very long time without high pressure manifolds. But if you do not have a analyzer, you do not have a blender, you can still give precise FiO2 levels with just a little bit of algebra. And that's basically the heart of this equation is realizing there's oxygen in the air we breathe, right, 21%, and we're taking a 100% O2 supply. And we can calculate the parts per oxygen per the parts per air. And you don't have to memorize this equation because we can really simplify this down. And what's called the magic box. They used to teach this in RT school many, many years ago, 20 years ago when I started, believe it or not. And only a handful of people I work with remember this. So we're just spoiled with technology. And it's really simple. So oxygen on this one goes on the left, air goes on the right. And it'll actually guide us through the math. So if we wanted 70% FiO2, and we can have no way to mix gas with the blender, we have 100% on the left, that's your oxygen flow meter. You have a 21% compressed gas source on the right, 20%. Move it through, subtract each side, and there you go. That gives us a ratio of 49 parts oxygen to 30 parts air. And if you simplify that down to 1.63 parts oxygen to 1 point air, you will get 70%. And you don't need an analyzer, you just need 2 flow meters. And we use an analyzer in line just to verify, and we eyeballed these because we're all limited to the equipment we have. We didn't have flow meters that go down to fractions of a liter, so we just kind of round to the nearest, and there we go. So this is our setup, and we're getting 70% exactly. But that's pretty low flow. If you need more flow and you need to see 70%, you just have to multiply that by how much air you're giving, right? So we're giving 1.63 liters for every 1 liter of air. So we multiply that by 4, and we get a total liter flow rate of 10.5, 4 liters air, 6.5 liters of oxygen, and we verify it again, and we get 70% again. So if you don't have this fancy equipment, you can still give precise FiO2 deliveries, but it's important you humidify that gas. And if you have an analyzer, you can just put that line and just get a feel for it. You don't have to do the math, but analyzers can be hard to come by as well.
Unfortunately, you've got your baby now on low-flow oxygen, but there are no pediatric beds anywhere in your region. This is, unfortunately, the reality of what we find ourselves in these days. So you're told you're going to have to board this baby for a bit. You update the family, but then how often do you need to go and check on them while you've got your busy ER going?
So from a nursing standpoint, we realize that you're in the context of a busy ER. This is not your only patient, but it really is good for these kids to lay eyes on them at least every hour, if not more often. Much of this assessment does not have to be very involved. This is kind of my general formula for a drive-by assessment, just kind of walking by, looking from the doorway, doing some therapeutic looking, as we call it. The things that you're going to want to look at are first their chest. You know, do they look like they're breathing faster, working harder or retracting more? Has their color changed? Are they looking sicker or grayer? And then it might be hard to see circumoral cyanosis with a pacifier, but just any kind of darkening of the mucous membranes. Another thing you want to look at is, are they slumped down in bed, or do they have, good position with their head midline and their airway open? And then the final thing that I look at in these type of quick assessments, between tasks, is the numbers. I try to really make a point to look at the child first and then correlate the numbers. I think that helps give you a sense of what you're dealing with and not falsely reassure yourself with thinking, okay, well, the SATs are fine. It really makes you think a little more critically.
So now this kid has been boarding in your ER for, let's say, about 12 hours, and you're going back for your exam, and you find that this kid has now gotten more tachypnic, more tachycardic, and the SATs are hovering right around 90, but already up to 3 liters. There's worsening retractions, intermittent intercostal retractions, course throughout, maybe some intermittent end expiratory wheezes, and he hasn't been really interested in feeding at all. The last wet diaper was about 6 hours ago.
So when we're thinking about increasing our support, first things first, as we've mentioned several times, is suction them first, make sure their airways are clear. We do need to hydrate them. It seems like this baby hasn't been eating as much. And we also need to think about their insensible losses that are occurring from their tachypnea and their likely fever. So you have some options. You can drop an NG tube versus get an IV. A lot will depend on, staffing and supplies and what can be done quickly and how their veins look. If you do go the IV route, you can give a bolus of 10 to 20 cc's per kilo of normal saline or LR. For your maintenance fluids, you are going to want to avoid hypotonic fluids. Typically, we'll use D5 normal saline. For the maintenance fluid rate, that can be tricky in a small baby, but the general rule of thumb that has been pretty well established is the 4-2-1 rule. So for a child, you will have 4 mLs per kilo per hour for the first 10 kilos of body weight, 2 mLs per kilo per hour for the second 10 kilos of body weight, and then for every 1 kilo of body weight above that, you would have 1 more ml per hour. So for a 15 kilogram child, you would have 40 cc's an hour for the first 10, and then another 2 cc's per hour for the next 5, which would be a total of 50 cc's per hour of total fluid. And then, as you increase your support, you might want to start thinking about whether they might need a high-flow nasal cannula. One thing that has come up is thinking about how to really juggle all of the things that are going on this small baby's face. If you are thinking about increasing respiratory support, needing an NG tube for hydration or decompression, you generally want to drop that NG tube first, so that is kind of out of the way, and then you can tape down the cannula. To the point of the NG tube, when placing an NG tube, you can look at the Broslow tape as a reference for the correct size for the size of the child. In general, an 8 French tube will work for infants all the way up to 5 years old. If you have the small 6 French tubes available, those are great for neonates, but not really necessary for most infants. You can find these procedures on a lot of different reference materials, but in general, to place an NG tube, you're going to measure from tip of nose to the earlobe, and then from the earlobe to the xiphoid process and umbilicus, and you'll pick kind of a point midway between those as your end point. You will want to use some Surgilube and pass it through the larger nostril side. And to check placement, the gold standard is truly an X-ray to confirm placement. You can also aspirate and test pH. I believe a decade ago in nursing school, I learned that you can auscultate, and that is common practice in many places. But on a small infant, you can hear things in the wrong places and they might seem correct. So really, aspiration and pH or X-ray should be how you verify that. Another point to the NG tube is once it's in, you probably want to figure out the logistics of where you will tape it in relation to the cannula, and you can work with a second person or your respiratory therapist to work that out. Logistically, I tend to tape the NG tube loosely to the forehead to keep it in place, hook up the cannula and get that secured with a second person, and then tape the NG tube over that tape.
There are multiple high flow systems available on the market. This is the one we use, and I'd recommend whatever you're comfortable with, you use that one. We start at a target flow of 1 liter per kilogram, 1 liter per minute per kilogram of the child, up to 2 liters per minute per kilogram. Good rule of thumb. Most important thing is when providing high flow therapy, you do not completely occlude the nares. Occluding the nares will inadvertently trap gas, potentially build up pressure. And that pressure needs to vent somewhere. If you don't have a high pressure manifold in the system, it could actually cause potential harm. So it's really important that they can breathe, they can open their mouth and cry, and the gas can escape through and around the prongs.
Can you use RAM cannulas to deliver high flow? Question from the audience.
You most certainly can, but if you're using RAM cannulas to deliver high flow and you're using them for CPAP, which they're not recommended for, but some centers do, you have to make sure with high flow you allow room around the cannula and the nair so that pressure can escape. But with CPAP, you want them to pretty much occlude the nair but not blanch the skin.
So let's say that now our little case patient is stabilized on high flow. We've gotten them up to 2 liters of flow per kilo of body weight and about 30% oxygen. And you've seen an improvement in the retractions. The respiratory rate has come down a little bit to the comfortable 60s. SATs are doing fine in the low 90s. And now the important thing is to update your bed query for where you want to send this child. Increasingly, number of hospitals are using high flow as a floor level, so it does not necessarily mean that this child has to be admitted to an ICU at this point in time. How hospitals divide high flow between floor and PICU does vary institution by institution. It can vary by how much oxygen is required, what the flow rate is per size, how old is the patient, what the diagnosis is. Some will say that if you're using high flow for a non-bronchiolytic, then that cannot be used on the floor, or if the child has any baseline comorbidities may dictate where the child lands. But as is the case these days, unfortunately there are no beds available, and so you're going to have to hold this patient in your ER still. Let's say that on your next recheck, unfortunately, that this child has not been settling down.
Illness.
And you have increased work of breathing with worsening retractions. The respiratory rate is now up to 75. The oxygen requirement has climbed up to now, let's say, 55 to 60 to get your SATs just hovering around 90. And unfortunately, there's decreased aeration in the bases bilaterally, and it's coarse just generally throughout. Let's say that like this little guy in the picture, he does not look great. He's head bobbing, he's retracting, but he's still able to hold a binky, or perhaps he has still a feisty cry, so he's not completely down and out.
All right, next you're going to have to go to non-invasive positive pressure. So there's several different delivery methods, such as a ventilator or bubble CPAP. You have different interface options. So a lot of places do use the RAM cannula. You can also use a scuba mask or infant CPAP prongs. The usual range that we use is usually 5 to 10 centimeters of water. We're really looking to keep the FiO2 less than 60%, so you can go up on your CPAP to target a lower FiO2.
So we said in the beginning that with bronchiolitis you do not need chest x-rays, and that still holds, but as the child is progressing out of the realm of hospital level of care and more towards an ICU level of care, it is very reasonable to consider broadening your differential. Perhaps this kid has lobar atelectasis or a large superimposed pneumonia that would be reasonable to consider getting a chest x-ray for. So don't feel hamstrung from using your own clinical judgment at the bedside. As you now are moving into positive pressure range, you are now in the PICU territory, and so you need to call around and update your bed request now for a PICU level bed. And unfortunately, the regional PICU thinks that maybe they'll be able to help you out in the next 6 hours.
And we just wanted to cover bubble CPAP again. So typically, it's used for less than 6 months old. There are many different interfaces. Like I said, RAM cannula is probably the easiest and very commonly used. You want to make sure that the nares are completely sealed for CPAP. So you want the room around it for high flow, like we said, but sealed for CPAP. You need to make sure that you increase your flow rate to maintain bubble if you're going to use a bubble system. So you want to make sure that as the patient breathes, the bubble doesn't stop. If the bubbling is stopping, you need to increase your flow rate. You also may need to place an OG tube to vent the stomach.
So tips and tricks to just be thinking about when you're moving into positive pressure. There are a variety of setups out there, and this is not the time that you want to be jerry-rigging. So again, reiterating, know what equipment you have ahead of time. Suctioning is going to still be really important for these kids. Just because they're on higher support doesn't mean you stop doing the basics. Having suction within reach at all times, you may need to use extension tubing and clamping the suction catheter to the head of the bed so it's within easy reach. You're now escalating in support, and the kid work of breathing is we're not over yet. So this is not the time to be pushing PO. Keep the kid at PO until you fully captured them and are on the wean at this point. And if you haven't gotten a peripheral IV and you're aiming for a PICU level bed, this is probably the time to work on getting your IV access.
So some things to think about with the IV access. You may be placing the only IV that this child has through transfer to a PICU, potential intubation, and maybe, quite a long stay. And it is very difficult to get IVs in babies, let alone dehydrated babies. So when you're thinking about your sites, you want to try to avoid the AC sites. While those are usually the juiciest veins, they are also the more proximal veins that you can see, and it is virtually impossible to keep a small baby from flexing their arms. When you have no other options but to place an IV in a flexion point, such as the antecubital fossa or around the ankle, really try to swaddle them accordingly, with one arm swaddled straight down or positioned so that they can move it as little as possible. In general, you want to try to work distally to proximally so that you're not destroying your available options for potential IV sites, assuming that there is a chance that these might, blow or not last. To keep your IV patent, that's incredibly important. In larger IV catheter sizes in adults, your 22s and your 20s, you don't have to be as mindful about flushing them. They usually stay open, but the small 24 gauge catheters will clot off very easily. You can use either a low volume KVO rate on a pump of just normal saline. That can be great, but it also can be a risk for tangling and pulling the IV out. So depending on your judgment, you could also choose to just frequently flush the IV. This standard for IV flushing and even for PICC lines and other catheters is to flush with pulsatile pressure, normal saline, and clamp immediately following the flush. Another thing to think about is how you're securing the IV. Babies are very wiggly, they can be, diaphoretic, so you really want to try to make sure that you're optimizing the dressing so that you don't accidentally lose an IV. You can use some skin prep if that's available to you to make the skin stickier, or Mastisol is another product that often works. When choosing tape, I find that silk tape or the micropore tape tends to be a lot better long-term than the paper tape. And while you may be inclined to really reinforce and fluff up the dressing to secure it, sometimes adding more things makes it more likely to get pulled out. So think about that. And then finally, a lot of IV boards and various products are available. Sometimes they can also put points of tension on the IV or, make it so that you can't see the site very well. So just be cautious of those. Also, if IV boards are taped on too tightly, they can cause undue pressure on an IV site. One thing that is pretty helpful if you have access to them are the arm sleeves, or sometimes they're called no-nos. It's a sleeve that goes circumferentially around the arm and can be unvelcroed for quick assessment. Here we have just a basic picture of an IV dressing. I tried to find a picture of a dressing of an IV in a place that's not great. So where this IV is placed, it looks like the baby could very easily kick it out. So how are we going to keep it in? While we do have a little bit of the catheter hanging off of the toe, it's very well taped down, and we've really tried to adhere tape to catheter and catheter to skin and keep it as flat as possible. As always with all IVs, you want to have good visibility of the insertion site as well. Here are some nifty little tricks that I've seen and tried myself. Like I mentioned before, the extras that we try to add can sometimes make things worse. Particularly the most common thing that we see are paddings of gauze to prop it up. That gauze will usually get dislodged, and then you've got an IV kind of flapping freely in the wind. And then adding extra things can just be risky from a pressure standpoint. Like, I've seen half medicine cups put on IVs, or, sometimes different popsicle sticks to secure it. Less is more, and, good adherent tape goes a long way with IV access.
When all else fails, though, you may need to think about an IO. My one suggestion is if you're using the Easy IO system, we've discovered that there's some confusion about the weights. The way the pink needles are designated goes from 3 to 39 kilos, whereas the blues go 3 kilos and over. So there's significant overlap. And what ends up happening is people err on the side of going with the pinks, and then they get dislodged. As a general rule of thumb, use your pinks only for your neonates. Anyone older than a neonate, so anyone really bigger than probably 3.5 kilos, you move to your use your blue needles, and then save your big boy yellows for your teenagers or your obese population. As a reminder about sites, the most common and easiest is your proximal tibia, but you can also use distal femur, distal tibia, and proximal humeral head. So a word on albuterol. So we've all been trained not to use it in bronchiolitis, and that is the vast majority of kids are not responsive to it. However, it's reasonable to think about in your older infants that are getting closer to the age where you might start thinking about asthma, especially if they have a strong family history of asthma or seasonal allergies. Anecdotally, we're seeing that the older children this viral season have a lot of bronchospasm, so it's reasonable to consider. But please, if you're going to use it, listen before and after, and if you see a clear improvement, then it's reasonable to continue. But if not, don't keep trying. It has shown itself not to be useful. So let's say that you've gone back and rechecked on your kiddo who's been on CPAP, so slight discrepancy on this picture, but do you think you can play it? We're going to see if we can play the video. Let's say that this kid has been boarding in our ER now for over 24 hours. It's now become day of illness about 3, and we see this depressed mental status, prolonged expiratory push. Perhaps the lips are even a little bit on the bluish side. This does not look like a good situation.
BiPAP, biphasic ventilation, is one potential next step you could take. It adds a additional level to the CPAP. So with each breath, they get a breath adjunct is a good way to think of it. The masks, the interfaces come in all shapes and sizes. None of the kids are going to be as compliant as the one showed in the picture here. But once they get on and they're breathing better, hopefully they'll calm down and be comfortable. And believe it or not, the masks that will go over the eyes and nose and mouth tend to be tolerated well. You don't think they would be, but they are. Many masks, many different styles. You can even make your own mask with a resuscitation mask and some tourniquets. But know your equipment is the send-out message.
So let's say that everything has been moving in the wrong direction for this child and you're starting to consider intubation. I will refer you to number 4 on the webinar series for this that gave some wonderful recommendations about what equipment and medications to use. But just to reiterate, children are not easy to intubate, so try to think about who is the most experienced if you're going to move this direction. Do you have in-house anesthesia? Do you have time to get the critical care transportation team to the bedside? Go ahead and,
Another thing to think about with the preparations to intubate from a nursing standpoint is, again, make sure that you have everything you need ready to go, ideally within an arm's reach. For positioning, that's going to be very much up to the provider, but one thing that you can do is get a backboard preemptively under the patient. It limits kind of slumping down in bed. You can turn the child to be perpendicular in the crib. Sometimes that gives better access, and then have a shoulder roll in case that is needed. Make sure that you have, meds pulled up, all of your, intubation meds, as well as some emergency meds like epi and atropine, if you would feel more comfortable with that. And then think about what you will need to do after intubation. So you're going to need to keep that tube safe, so have restraints available or the no-no devices. You're going to need some more suction for the inline suction on the ET tube or just general suction on the ET tube with an open catheter. And then you're probably going to be putting the kid on some sedation. So make sure that you have IV pumps available, have it ordered from pharmacy ahead of time if it needs to be made up and ready to go. And then think about, if this goes poorly, if the kid decompensates, have your code cart nearby with your meds and your reference materials. And then when you're intubating a patient, you are going to need to think about your staffing ratios and maybe pulling in another nurse to have closer eyes on that patient.
So as was stressed in the earlier webinar about intubation, intubating babies is not easy and can easily get complicated. So do you really have to intubate? How dire is this current situation? Are they frankly apneic despite using non-invasive positive support and suctioning? Have their mental status declined concerningly? Are they in a worsening shock state? Is the hypoxia becoming refractory, meaning that we're well above 60% oxygen and we're not really even hitting mid-80s or 80% SAT? Update your referral PICU. They are standing by and happy to help try to triage, brainstorm, and you'll need to update your bed query if you haven't already. And just to reassure, the average tachypnic baby with bronchiolitis that doesn't have much of an oxygen requirement, they can look kind of punky and tachypnic, but they can puff along just fine for quite a long time. So I offer that as reassurance that you don't maybe have to intubate as rapidly as you might feel pushed to do so in perhaps your older adult population. Another piece of advice is the rate of co-infection. So the severe bronchiolitics, meaning the ones that are getting intubated or admitted to the PICU, those have, from the literature, about a 25 to 40% chance of having co-infected bacterial pneumonia. And those kids are associated with increased lengths of stay, increased ventilator days. And so if you've got a sick kid in front of you, don't be afraid to start empiric antibiotic coverage if they've rapidly progressed to the point of ventilation.
All right, so you're now prepping for transport. One thing to note, a lot of transport teams can't do high flow on the truck, so they're kind of limited there. So you may have to trial low flow, see if that works. Another thing though, if they can't tolerate the low flow, you may have to consider non-invasive, such as CPAP, at least for the transport. Or if they're just too unstable for that, you might just have to intubate them. Or if they can wait until your transport team arrives and intubate them.
And that's it from our perspective. Thank you so much for tuning in.